Thank you for joining the National Pancreas Foundation's virtual education webinar this evening. The National Pancreas Foundation's mission is to provide hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. Some of our featured programs include the Animated Pancreas Patient, our state chapters that assist with education, fundraising, and patient support groups, and our physician programs that include research grants, medical education, and our annual Fellows Symposium. We are always looking for volunteers to help support our mission. For more information on how to get involved, please email us at info@pancreasfoundation.org. Tonight's program will cover nutritional considerations in pancreatitis and pancreatic cancer with Dr. Anna Evans Phillips of the University of Pittsburgh's Medical Center and Katherine Goebel of Cedars-Sinai Medical Center. Dr. Anna Phillips is an assistant professor in the Department of Medicine, Division of Gastroenterology, Hepatology, and Nutrition at the University of Pittsburgh. She graduated from the University of Pittsburgh School of Medicine and completed training at Yale, Columbia, and the University of Pittsburgh for her residency, GI fellowship, and medical pancreatology fellowship. She is the medical pancreatologist whose main research focus is on assessment and treatment of pain and chronic pancreatitis. Katherine Goebel is a registered dietitian at Cedars-Sinai Medical Center in the Small Bowel Diseases and Nutrition Program with the Pancreatic-Biliary Department. She holds a bachelor's degree in clinical nutrition from the University of California, Davis, and a master's of science degree in family and consumer sciences from California State University, Northridge. She completed her clinical training at LAC and USC Medical Center and went on to obtain a certificate in pediatric nutrition and a second certification in nutrition support management. She provides medical nutrition therapy to patients with a wide variety of gastrointestinal disorders. So during the presentation tonight, please use the Q&A section to ask your questions, and those will be addressed at the end of tonight's presentation. I want to thank both of our presenters tonight, and thank you all for supporting the mission of the National Pancreas Foundation. I'll turn it over to you, Dr. Phillips.
Thank you so much, Trish, and thank you so much for having both of us. This is a real pleasure and an honor to be asked to present. I appreciate the generous introduction. And so this evening, I'll be presenting on the initial part of the evening, just talking specifically about nutritional considerations for patients with pancreatic disease. And an initial disclaimer is that I'm primarily a medical pancreatologist focused on chronic pancreatitis. And so this evening, my presentation will be focused around adult patients with chronic pancreatitis. Some of these same principles, though, apply to both patients with acute pancreatitis and recurrent acute pancreatitis, as well as patients with pancreatic malignancies. And so certainly we welcome questions about all of those disorders. But again, my initial presentation will be focused specifically on chronic pancreatitis. And so first, I have no financial or other conflicts of interest to declare. And an additional caveat to this presentation is that underlying this, every person's nutritional situation actually is quite unique. And so this presentation unfortunately can't replace any physician, nursing, or nutritionist recommendations for any individual's unique situation. We always would recommend talking with a pancreatologist or other medical professional directly about the nutritional recommendations that would be needed to optimize any individual's plan. And so in brief outline, we'll talk about nutritional challenges in adult chronic pancreatitis broadly. First, we'll talk a little bit about why this is important. Why does malnutrition then happen in chronic pancreatitis? And then some basic information about the concomitant disorders of exocrine pancreatic insufficiency and endocrine pancreatic insufficiency or diabetes. And so the definition of chronic pancreatitis is that it is a fibroinflammatory disease of the pancreas, and it's a result of inflammation that is not seen to either heal or improve. It results in permanent irreversible damage to the pancreas, which can manifest then with chronic pain, the inability to make digestive enzymes, and the failure of the pancreas to be able to control blood glucose level. Now, interventions to alter the course of the disease are very limited. Essentially, we counsel patients to abstain from alcohol, to abstain from tobacco, which we know is an independent risk factor for progression of chronic pancreatitis. There are several endoscopic therapies which can be used to unblock the main pancreatic duct if that is part of the underlying issue that is causing progression of disease. And in some patients, there are surgical therapies which can be used in order to improve the flow of pancreatic disease or remove the pancreas, which can be a source of much pain and other problems. The last thing that is very rarely talked about, or at least until recently has been rarely talked about, is actually nutritional therapy. And my colleague, Katherine Goebel, is going to talk about this more extensively in her presentation, but essentially trying to guide nutrition for patients to not only support them through their disease, but also to help concomitant issues that arise in the course of chronic pancreatitis or other pancreatic diseases, and improve the patient's overall situation. Why is malnutrition important in chronic pancreatitis? Malnutrition can lead to another disorder called sarcopenia, a disorder of frailty and difficulty maintaining adequate strength to perform things like normal daily activities of living. And this syndrome of the loss of skeletal muscle mass and loss of strength has been previously associated actually not only with decreased quality of life for patients, but increased hospitalization and decreased survival times. Malnutrition in chronic pancreatitis can also lead to vitamin and mineral deficiencies. You can see here that in several small studies, actually in recent years, we've seen a significant portion of patients with chronic pancreatitis affected by deficiencies of things like vitamin A, D, and E, as well as zinc and magnesium. And there are several other micronutrients not listed here, which have been shown to be clinically significant in this patient population. Now, certain aspects of malnutrition in chronic pancreatitis can be very pronounced in this patient population. Weight loss, specifically unintended weight loss in patients who are underweight, are very common. Again, vitamin and mineral deficiencies are frequently seen. Complications of these deficiencies can include things like mineral bone disorders or osteoporosis and osteopenia. Multiple factors contribute to underweight and malnutrition in chronic pancreatitis. The underlying issue, of course, is calories in versus calories out in many of these patients. There is a huge limitation, though, to the intake of adequate calories, which we recognize as clinical providers for this patient population. Postprandial pain, or pain that occurs when patients eat, can limit the amount of nutrition that patients are able to take in at any one time. This can lead to a fear of eating, especially for those who have had the experience where eating is a trigger for an attack of recurrent acute on chronic pancreatitis. Many patients suffer from chronic nausea and have a loss of appetite, actually, which limits their ability to eat. Additionally, on top of these limitations to the intake of adequate calories, many patients are losing calories for other reasons. Oftentimes, patients have recurrent episodes of vomiting, which occur as a complication, again, of the nausea and abdominal pain that occur with pancreatic disease. And a number of patients actually suffer from a disorder called steatorrhea, or a fatty diarrhea, which occurs by the loss of the appropriate amount of digestive enzymes occurring from, digestive enzymes that are being secreted from the pancreas, resulting in malabsorption of fat and a subsequent fatty diarrhea, which contains a lot of the nutrition that patients had previously taken in. Now, the pancreas, as many of you may know, has two major functions. The pancreas has an exocrine function, where it creates digestive enzymes that break down protein and fat. And then it also has an endocrine function, which is where cells inside the pancreas make insulin, glucagon, and other hormones that are intricately involved in regulating blood glucose levels. Over time, as patients have the loss of pancreatic function related to scarring or surgery where it is removed piecemeal or in a large portion, may lose each of these functions over time. Sometimes this happens gradually after multiple episodes of acute inflammation. Sometimes this loss of pancreatic function can happen very quickly after a very severe episode of acute inflammation. Again, it can happen sometimes following surgery, such as for cysts or tumors of the pancreas. And some patients, furthermore, undergo complete removal of the pancreas, which can remove these two functions altogether. As a consequence, though, of the scarring, destruction, or surgical removal where part or all of the pancreas may be removed, the pancreas, again, can lose the ability to perform one or both of the functions that I previously mentioned. Pancreatic exocrine dysfunction is a major problem in this patient population. At its baseline, the pancreas has a large secretory capacity, somewhere between 1.5 to 2 liters per day of digestive enzymes and other fluids, which help in normal digestion. Some of these components of pancreatic fluid include sodium bicarbonate and the aforementioned pancreatic enzymes that digest fat and protein. You may have heard of some of these names, including amylase, lipase, and protease, which are just some of the enzymes that are secreted by the pancreas. As I previously alluded to, individuals who lose the exocrine capability of their pancreas may have difficulty digesting and absorbing fat and protein. This can lead to a syndrome called exocrine pancreatic insufficiency, and this is a syndrome that specifically occurs secondary to the loss of the ability to digest fat and protein. Exocrine pancreatic insufficiency is most often seen in late-stage chronic pancreatitis, and it's been estimated that patients need to lose somewhere about 90% of their pancreatic parenchyma or their pancreatic tissue in order to suffer from exocrine pancreatic insufficiency. What we've learned in recent years, though, is that actually exocrine pancreatic insufficiency can happen in a number of situations and can happen in a more subtle fashion for patients than is described here, where patients who lose a smaller amount of their functioning pancreatic tissue may suffer from symptoms of exocrine pancreatic insufficiency, even if they still have a good portion of their pancreas intact. Additionally, patients may lose some degree of their exocrine function after an episode of acute pancreatitis, and sometimes it may return gradually over time. There are a lot of subtleties to exocrine pancreatic insufficiency that are currently being examined actually by many research studies that are ongoing around the country and around the world. The degree of dysfunction of the pancreas, though, in chronic pancreatitis often parallels the degree of fibrosis. But unfortunately, we have pretty limited tools to assess exocrine pancreatic insufficiency prior to its late stages. And so, as I mentioned, the research studies that are ongoing, many are aimed actually at trying to assess exocrine pancreatic insufficiency and its subtleties prior to it being a very dramatic phenomenon. The most obvious symptoms, though, of exocrine pancreatic insufficiency include weight loss, steatorrhea, or that fatty diarrhea that I mentioned, and then fat-soluble vitamin deficiencies, which can be detected sometimes by simple blood tests. The treatment of exocrine pancreatic insufficiency is to supplement with pancreatic enzymes exogenously, or in other words, by mouth. And this is something that Katherine will discuss a little bit later on. Now, just briefly to touch on these issues of vitamin and mineral deficiency, fat-soluble vitamins have to be accompanied by digested fat in order to be absorbed. In other words, they have to be accompanied by fat in order to be uptaken from the intestines. Low levels of fat-soluble vitamins and minerals can lead to further complications that are easily avoidable with adequate supplementation of pancreatic enzymes. We always recommend at least annual monitoring of the levels of fat-soluble vitamins and commencing supplementation of both vitamins and then pancreatic enzymes in the setting of any detected deficiencies. Now, as I mentioned before, there are a number of possible vitamin and mineral deficiencies that can occur. And this just suggests actually some of the symptoms that patients can present with when they have vitamin or mineral deficiencies in exocrine pancreatic insufficiency. This can include things like night blindness with vitamin A deficiency, osteopenia or osteoporosis in the setting of vitamin D deficiency, bleeding complications with vitamin K deficiency, and anemia with things like vitamin B12, zinc, or copper deficiency. Moving on from that, I wanted to discuss just a few things actually about diabetes, because that's a huge nutritional consideration in patients that are concomitantly affected with diabetes and pancreatic disease. So diabetes, its presence further complicates nutrition, of course, and it's often advisable to establish care with an endocrinologist at the same time as your GI doctor. Diabetes in the setting of pancreatic disease can be very challenging to manage. Pancreatic endocrine dysfunction is a very specific type of diabetes. And so pancreatogenic diabetes, or a type 3C diabetes, is something that occurs with the loss of the pancreas's ability to produce adequate amounts of the previous hormones that I mentioned. The prevalence of diabetes related to pancreatic disease varies widely in prior studies, and it's been estimated to be somewhere between 25 and 80% of chronic pancreatitis patients who have diabetes related to their pancreatic disease. There's increased incidence of diabetes actually with increased duration of chronic pancreatitis. But to date, there's actually no universally accepted diagnostic criteria for diabetes that comes from pancreatic disease. There have been proposed diagnostic criteria, which include the concomitant or simultaneous diagnosis of exocrine pancreatic insufficiency, and the proposition that pancreatic abnormalities have to be seen on imaging to consider the presence of diabetes related to pancreatic disease. And then that there also need to be the absence of related autoimmune markers for a type 1 diabetes. However, again, this is an area of many research studies that are ongoing around the country, and it's something that I'd encourage you to talk with your pancreatic providers about. In pancreatic endocrine dysfunction, there are several universal phenomena, though, that are agreed upon and that are generally occurring. There is inadequate insulin that is produced in chronic pancreatitis that often results from destruction of pancreatic tissue or the resection of parts of the pancreas. In addition to that, inadequate insulin will circulate as cells further develop resistance to insulin. And this can be exacerbations of underlying type 2 diabetes. The possibility that there is an immune component to this type of diabetes is less well understood, and again, is currently being researched. But one last point that I wanted to touch on actually is just the avoidance of alcohol and tobacco in pancreatic disease. Alcohol is an independent risk factor for chronic pancreatitis, and tobacco is also not only an independent, but dose-dependent risk factor for chronic pancreatitis, meaning that the more that a person smokes tobacco, the more likely that is to contribute to the progression of pancreatic disease. Tobacco smoking attributes about 25% of the risk for chronic pancreatitis, and its effects are actually stronger in alcohol-related chronic pancreatitis. Patients often ask how frequent it is that if they have an episode of acute pancreatitis, a single episode, how often would they go on to develop chronic pancreatitis? The overall number is small, but it's at least 4% of patients who have a single episode of acute pancreatitis will go on to further develop chronic pancreatitis. In alcoholic acute pancreatitis, rates are higher. After 2 years, estimates may range from widely between 13 and 90% who would progress to chronic pancreatitis. And after 10 years, estimates range in a little narrower of a range, but 16 to 66% may progress. Continued alcohol use and continued tobacco use will hasten progression. And so I raise this just because avoidance of alcohol and tobacco is a very common refrain in chronic pancreatitis specifically, and oftentimes in all types of pancreatic disease. I raise these facts and prior is an important thing to discuss at the beginning of any type of conversation about nutrition and chronic pancreatitis. I wanted to mention a couple of other resources actually related to nutrition, including a cookbook that was published by the National Pancreas Foundation in the last year and a half. And so this cookbook contains a lot of recipes that are supportive of a person who is following a low-fat diet. And it has quite a wide variety of recipes and is available at this link here. The National Pancreas Foundation also published a pocket guide, actually, which is helpful for the shopping and obtaining of kind of nutritional facts for any person, again, who is suffering from pancreatic disease, but trying to adhere to pancreas-friendly dietary practices. In addition to that, just broadly speaking, the U.S. dietary guidelines have a lot of useful information for people who are trying to educate themselves about low-fat diets. And then lastly, the Cystic Fibrosis Foundation is one that has a lot of information about low-fat diets, or excuse me, about underlying pancreas disease and can be helpful for patients of all ages who are suffering from pancreas disease related to cystic fibrosis. And so with that, I'll end my portion of the presentation and open it up to Katherine, who's going to talk a little bit more about specific nutritional practices in pancreas disease. Thank you.
Okay, thank you, Dr. Phillips. So let's get started. So my name is Katherine, and I'm going to be talking today about nutrition and pancreatic disease, mostly from an outpatient long-term management perspective, because that's the role I have here at Cedars-Sinai. Managing moderate to severe acute pancreatitis in the hospital setting can be very different than what people deal with at home. So I decided to do this presentation in the format of the most common questions I'm asked as a dietitian. I'm also not going to cover diabetes in this talk because the treatments are just so highly varied, depends on type, severity, use of insulin, and so on. I have nothing to disclose, and I wanted to mention that I'm not endorsing any specific brands or companies. If I do mention any, it's just to use them as examples. The objectives are to identify what constitutes a low-fat diet, list alternative food and cooking choices when following a low-fat diet, identify methods used to facilitate weight gain, understand when and how to use pancreatic enzymes and supplements, and identify the available options for nutrition support. So dietary fat and pancreatic function are very much linked, as Dr. Phillips covered, and I'm sure most of you know. But just to quickly recap, as the food you eat leaves your stomach and enters your duodenum, which is the very first part of the small intestine, it stimulates the release of enzymes from the pancreas. The amylase will break down carbohydrates, protease breaks down proteins, and lipase breaks down fat. Some studies have found that a low-fat diet may help pancreatitis patients manage their abdominal pain, but this is not necessarily the case for everyone. So a low-fat diet means that the daily intake is limited to no more than 50 grams of fat per day. There are even lower fat restricted guidelines, like 25 to 35 gram fat limits per day, but those diets really should be transient and not used long-term. And the main reason for that is because we all require a certain amount of fat to meet our essential fatty acid needs. Without any fat intake at all, especially essential fatty acid deficiency can develop within a few weeks, 2 to 3 weeks usually. And symptoms of that can include dry scaly rash, hair loss, increased susceptibility to infection, and poor wound healing. But you can also develop a deficiency while on an ultra low fat diet for a long period of time. So where is the fat in my diet and what can I choose instead? So I'm not going to go into each item specifically, don't worry, but I wanted to point out that for every high fat item, a lower fat alternative does exist. Especially in today's market, there really is a non-fat or low-fat version of really any animal product you want to eat out there. I'm often asked, oh, so I'm on a low-fat diet now, it means I can't eat beef, right? And the answer is no, because there are lower fat versions of beef like sirloin tip or lean or extra lean ground beef. And, if someone has a sweet tooth and really loves and misses eating ice cream, there are lower fat options like Halo Top and Arctic Zero. Some of the major plant sources of fats are avocado, coconut, and nuts, but dried beans and peas are okay. And for our vegetarian or vegan patients, most of the meat alternatives made with soy or wheat are already low fat as well. So tips when grocery shopping. I wanted to include a few practical tips on grocery shopping and cooking tips in the next slide. So when in doubt about an item's fat content while grocery shopping, check to see if there's a nutrition facts label, which most items in the store will have. When you look at the label, I first want you to look at the serving size at the top of the label, and then look at the fat grams underneath the nutrient section. If you're just comparing foods based on the fat gram amount listed, but the serving sizes are varying, then you may be missing the true amount of fat that you'll end up eating. We also want to ignore the percentages on the right side of the label because these are based on a 2,000 calorie regular diet and are not applicable to everyone, especially someone on a specialized diet. So I asked my patients to take a look at the front of package labeling and just, take it with a grain of salt. Keep in mind that this part of the package is advertisement driven and can be a little deceptive. For example, I list two things here. You may see a cream cheese product that says reduced fat, which is 1/4 less fat or 1/3 less fat. But these statements are comparing this lowered fat food to their standard fat counterparts, which is to say that if you have a very high fat item, a reduced fat item of a high fat food may still have a ton of fat in it. So you need to just read the serving size and then read the grams. So a few tips when cooking. Once you've purchased your food that requires the cooking like fish, vegetables, meats, etc., a major factor in how much total fat you'll end up consuming is based on how you prepare it. So any method that requires oil or butter, like frying, for instance, can be prepared instead by methods that require no fat or very minimal amounts of fat, like roasting or steaming. For my patients that miss fried foods, which is completely understandable in my opinion, I recommend that they try preparing whatever food that was in an air fryer, which does leave the food pretty crispy on the outside, but still moist and tender on the inside. Then just a few other things: remove, skin from poultry and trim visible fats off meats. Cook with a nonstick cookware. There's a lot of good pans out there that don't require any oil or butter on them, and the foods will not stick to them. It's really good. And then for flavoring, because I know a fat restricted diet can be a little bland sometimes, turn to seasonings and sauces that don't have fat, like teriyaki, herbs, salt, or squeeze a little lemon or lime in there too. So how should I monitor what I'm eating? There are a ton of different apps out there that can track your food intake for the entire day, so you don't have, so if you do have a specific fat gram limit, it'll total up the food items for you. I tell patients that if you're willing to track your food intake, start by being very diligent about it in order to learn more than anything. Because once you're familiar with the fat content of common food items that you like to eat, portion sizes, what they look like, and what a low fat day kind of looks like, you don't need to keep tracking. You'll get to a point where all of it will be second nature to you, but it does take some studying and observing to get there at first. Sometimes it's hard to tell how many fat grams are in something that's more of like a mixed meal, lasagna or pizza, but the apps have been pretty good about starting to include these, and websites sometimes have more information and extensive lists than what you can find on apps. And you can also get cookbooks that include the number of fat grams present in the whole recipe, which is why I really like the National Pancreas Foundation recipe book for my patients. It takes the guesswork out of cooking from scratch. You don't have to count each individual part of the recipe. You just know the whole recipe provides this much fat. And so you can plan out your entire day using this cookbook to fit your fat gram restrictions. It can be hard to gain weight on a fat restricted diet because fat is the most calorie dense micronutrient out there, but it's absolutely doable. One way is by adding MCT oil to your diet. And MCT oil stands for medium chain triglycerides. Most fats that we eat come in the form of LCTs though, which stands for long chain triglycerides. But MCTs are special in that they don't require lipase or bile to be digested and absorbed. So they bypass much of the process that LCTs have to go through, which means they may be better tolerated in patients with pancreatic disease. And MCT oil also gives you a lot of bang for your buck. You can see here that it provides over 100 calories per tablespoon, and it doesn't need to be counted in your total fat gram intake for the day. I always tell patients to have it be completely separate on its own. The only downside is that it doesn't contain essential fatty acids, so you can't be taking MCT oil in isolation. You still need some other fats in your diet. There are a lot of options out there for nutrition supplements, oral nutrition supplements. There are your standard shakes like Ensure or Boost, and then there are high protein gelatos and ice creams like Thrive, which we actually have available to all inpatients here at Cedars, and it's very well liked. It tastes good. And then there's also hydrolyzed or pre-digested shakes like Kate Farms Peptide. The hydrolyzed shakes are far more expensive, usually less palatable, and should really only be used if a person, has poor tolerance to whole foods, as well as, standard shakes that they've tried already. Another option is to make your own. So you buy a protein powder, blend it up with the fruits you like, yogurt, maybe a little MCT oil, and it'll taste a lot better. And you can tailor it to your own specific likes and dislikes. Also, start some physical therapy or exercise. It's really important. If you're eating more calories, your body will need somewhere to put those calories. So we want you to have a nice, healthy mix of both muscle and body fat. So if you're exercising, you're going to use the calories to build muscle and gain some strength. And lastly, diet advancement, which I'm going to go into in the next slide. Your clinical status changes over time. It ebbs and flows, and something that you weren't able to do maybe 3-4 months ago, maybe something you can do now. So can you safely eat more fat? A lot of patients ask me this, and the short answer is most likely. There's really good data out there to suggest that moderate fat intake is not associated with disease progression and serious complications. But having said that, diets higher in fat can be associated with longer time periods of reported abdominal pain. Anecdotally, I'll tell you that many chronic pancreatitis patients have an individualized threshold for how much fat they can tolerate, and it may not fit into the low-fat diet category. It may be above that. It could even be a standard fat diet with about 30% of total calories coming from fat. And then during an acute on chronic flare, patients may back off of fat for a few days or a few weeks and then slowly reintroduce it. In my patients who have had a Goebel or total pancreatectomy, you might be limited by how much fat you can eat, mostly by how well the pancreatic enzymes work for you. And I'll get more into that in the next slide as well. So there are a few different ways to increase your fat intake. So definitely check with your dietitian which one would be best for you. But I'll mention a couple methods I use. And one is to increase intake by about 10 grams of fat per day every 5 to 7 days or longer. I like this stepwise gradual increase method for people who are ultra sensitive to diet changes because it's very methodical and you can kind of pinpoint exactly where your own personal threshold for fat tolerance is. And another way is that I'll ask patients to eat their typical day diet on the low fat and then add one higher fat food item into the day. So this is really a great method for people who miss eating a specific food. So like, let's say if that's avocado or it's butter or chicken skin, They know if it's going to become a triggering food for them. And at the same time, they'll also be kind of advancing the diet and trying more things. So when and how should I consume pancreatic enzymes? Some signs that you may need pancreatic enzyme replacement therapy are unintended weight loss, diarrhea or greasy stools, constipation. Yes, constipation does happen, bloating, and abdominal distension. Many providers will try patients on enzymes first if they have a diagnosis that already puts the patient in a higher risk category of developing pancreatic and exocrine insufficiency. Like if you've had pancreatic surgery or a confirmed diagnosis of chronic pancreatitis already, then they may just put you on that before doing like a stool study test and see how you respond. So if your provider does decide to order stool studies, they'll likely check how much fat is being excreted in your stool, because any fat that you eat that doesn't get digested and absorbed has to go somewhere. And the other stool test is pancreatic elastase, which is a measurement of how well your pancreas is producing and secreting enzymes. But if you have very watery stools, this can dilute the test and invalidate the results. So it should really be used only in the cases that are appropriate for it. So how to take the enzymes. They only work on the food they come into contact with. So taking an enzyme pill in the morning with all your morning pills and then you don't eat for an hour, it's not going to work. I always counsel my patients to take the enzymes with the first bite of food and to carry their enzyme bottle with them everywhere, because you don't know when you're going to get hungry or when you're going to be around food. Some pharmacies will put the enzymes in a smaller prescription bottle if you ask them, so that you can have a more portable dosage to carry around other than those giant big bottles that they give out. If you're taking the enzymes exactly as you should and you're not missing any dosages, but you still have symptoms, it could be a simple dosage matter and you may need a higher lipase count per pill, or you may need more pills with your meals and snacks. So these two charts right here show kind of a starting point as to how much your provider may prescribe for you based on your weight. Not every provider knows everything about dosing enzymes, and they may have you on a dose that's too low, or you may be someone who needs far more pills than what the chart says. Either way, just keep in touch with your provider for prescription changes. Should I use any vitamin or mineral supplements? Anytime someone is on a restricted, not regular diet, I recommend they start taking a standard multivitamin with mineral supplement. And I do this because whenever you consistently exclude a wide range of foods from your diet, you run the risk of not meeting 100% of your micronutrient requirements. Add on that patients with pancreatic disease have good days of eating and they have bad days of eating. So it's best to just cover your bases just in case the bad days start to build up. Because fat digestion is often impaired in patients with pancreatic disease, they have a greater risk of developing fat-soluble vitamin deficiencies, as Dr. Phillips mentioned. She kind of went over this. The vitamins are A, D, E, K. Having said that, though, I would not go out and start adding high dosage supplements above like a maintenance dose without first confirming that you even need it. And that can be done with a simple blood test. So based on your results, a healthcare provider will be able to give you guidance about specific supplementation dosages, because you can develop toxic levels given that they're fat-soluble vitamins. I also want to quickly mention zinc, because that's another common deficiency I tend to see in my patients, especially in those who have dealt with chronic diarrhea. Diarrhea can be both a cause of zinc deficiency, but it can also be a sign of one. So supplementation may help improve the diarrhea if it's related to a deficiency. In a recent study from 2019, they found that about 26% of patients with chronic pancreatitis studied had a laboratory confirmed zinc deficiency. And that deficiency was most common in patients that have EPI and in patients who are older than 60. So when should I consider nutrition support? I wanted to include a brief slide on this topic because I'm asked about it quite frequently. But I want to point out that it's a very complex issue that should be discussed with the multidisciplinary team. and you have exhausted all the other options like enzymes and the other nutrition interventions I discussed. So enteral nutrition, otherwise known as tube feeding, is the delivery of a formula into the gut, which bypasses the act of eating orally. So I found some studies that indicated about 5% of patients with chronic pancreatitis end up needing long-term tube feeds. For shorter term usage though, a temporary tube can be placed through your nose, like you see in the picture here. And for longer term access, a more durable tube can be placed endoscopically by interventional radiology, and in some cases by a surgeon if needed. In patients with pancreatic disease, I see most patients who need tube feeds being fed past the stomach and into the intestines, the jejunum specifically, which decreases pancreatic involvement in the digestion process. We also have many specialized formulas available to meet the needs of patients with exocrine insufficiency. So some patients are unable to tolerate tube feeds despite the specialized formulas and any medications that might assist them with tolerance. And this is when we move to parenteral nutrition, which is IV nutrition directly into your bloodstream, bypassing the gut entirely. So the ultimate end decision to move forward with or without nutrition support is up to the patient, and therefore really all discussions around this rather sensitive topic should be patient-centered and using multiple members of a team for their input. And that's it. And I think we'll take some questions now. So if you want to type them into the chat, Dr. Phillips and I can answer.
Excellent. Thank you so much, Catherine. That was fantastic. And yes, indeed, we have some questions. So I wanted to start actually by posing several to you that had come through. A couple of these specifically are actually related to recommendations about grams of fat per meal, whether for adult patients, you should, for example, take your total daily allotment and divide it equally across the day, or are there specific recommendations that you make for the timing or size of meals during the day?
That's a great question. I am asked that a lot. And I like for people to take their total fat grams and try and spread it out as evenly as possible throughout the day. Of course, you know, it doesn't have to be exact. It just has to be kind of spread out, because your pancreas will do better, or your whole digestive system really will do better if you're kind of slowly metering in the nutrition that it receives.
Wonderful. There was an additional question actually about whether you might have any recommendations for pediatric patients. I'm not sure about any pediatric practice that you have. I did want to mention that I believe the National Pancreas Foundation is actually hosting a session on pediatric pancreatic disease later this year. And so certainly tune into that. But in the interim, you know, for example, for a patient who is young, maybe around 7, with a genetic etiology of pancreatitis, are there recommendations you give to their parents if they come to you?
You know, I actually haven't worked with pediatric pancreatitis patients, so I can't really answer that. But I will tell you that a lot of what I talked about can be applicable for all age ranges. And maybe Dr. Phillips, you have more information on that.
Oh, that's a great question. I'm an adult pancreatologist, and so I would defer that, I think, to my my pediatric colleagues. And so we'll probably wait for a later session on that. Certainly, nutrition is paramount in the early years and stages of development. So it's something I would reach out to your pediatric providers about. Excellent. We have another question here, actually, on would you recommend a comprehensive food study or food sensitivity study? How does that figure into your recommendations to patients when they come asking about that?
Yes, so we get those tests a lot. And what I usually tell patients is there aren't enough validated studies to really use it in my practice. So Dr. Phillips can probably speak more to this as well, but I know that a lot of those ones are just testing an immune sort of response to it. It's not the same thing as an allergy or even an insensitivity. It just means that your body is responding to its presence. So for that reason, I really don't use those in our practice.
I agree. That's a great question. And certainly food sensitivities can further complicate nutritional intake. And if there's underlying pancreatic disease, the whole picture can become complicated quite quickly. Specifically as relates to pancreatic disease, we also don't routinely send food sensitivity studies because the presence of pancreatic disease actually, it creates a different digestive milieu than what the food sensitivity studies are looking to diagnose. And so I think if there is suspicion for a specific food sensitivity based on, a food diary or things like that, there may be reason to pursue those studies with an allergy immunology provider or with other physicians. But in pancreatic practice, it's not something that's generally done routinely. Great. And so one other question for you, Katherine. So are there any other foods that you find patients reporting to you that affect pancreatitis negatively?
Yeah, it's kind of tough to answer that because it's very individualized. There isn't really like one specific thing that patients tell me across the board is troublesome for them. I will say that perhaps more fish and poultry type of meat proteins might be a little bit better tolerated if you're fresh out of a acute flare, and then introducing red meat again down the line as you're doing better. But yeah, it's so individualized, definitely.
Excellent. One specific question for you. Can you give good tips on how to find a good dietitian for someone who has chronic pancreatitis?
That is a great question. So our program is great because, as you all, I'm sure know, a lot of insurance companies do not reimburse to see a dietitian. So if you can find a physician or a nurse practitioner who has a dietitian already in their program, in their office, my visits are included with the doctor's visits. So that might be a good method to get an affordable dietitian for you in your area.
Thank you for covering that. That's a very important topic. One of the things that I just want to make mention of is that as the questions are coming in, we'll certainly do our best to answer everything that we can. Rest assured that any questions we don't make it to this evening, we have received them if they've come through the question and answer box, and we can respond to you individually as needed. And so moving on, actually, since we've got a lot of interesting topics to cover here. Nutrition in pancreatic cancer. Perhaps, Katherine, you could just talk a little bit about your experience with pancreatic cancer patients and how your recommendations might differ for those patients as opposed to patients suffering from chronic pancreatitis.
Yes. So in patients with pancreatic cancer who are devoid of, pancreatitis type pain, there really isn't a fat restriction, except kind of like what I mentioned in my talk. If you are requiring, pancreatic enzymes, you may not be able to tolerate a high fat diet. It kind of depends. I've seen patients who are taking, 5 or 6 pills at a meal, and they'll still have diarrhea if it's a fried food. So it may just be more of a, are you taking your enzymes at the right time? Is the dosage right? But in terms of the cancer itself, there's no link or correlation to fat intake or anything else like that.
Excellent. Thank you. Another interesting question actually has to do with the content of enteral feeding or tube feeding. I wondered if you can comment at all on the types of fats that are present in enteral tube feeding. One of the specifics here is about the formula vital, but in general, how do you think about cholesterol content and triglyceride content of tube feeds and its effect on patients' health?
Yes, great question. And I do notice that patients will tolerate formulas quite differently. For instance, I'm just mentioning brand names, but I'm not endorsing them at all. So Peptamen, for example, I look at the ratio of LCT fats to MCT fats in terms of tolerance. And so Peptamen has a very high ratio. And so they have 70% MCT and 30% LCT, whereas other, hydrolyzed formulas are going to be kind of flip-flopped the other way. And so even if the protein is pre-digested and broken down, you have to look at if the fat is as well. And then as far as, like other types of things to look at, like cholesterol and stuff, I really don't look at that as much. If you have issues with high triglycerides, that can be a whole talk on its own, but I look more at what the source of the carb is. Is it high carb, simple sugars, like that kind of stuff for the triglycerides?
On that same note, or rather as a follow-up question, you had mentioned actually that many patients come to you with questions about specific types of restriction diets. And I wondered how you usually respond to questions about things like the keto diet or many other options. And so how do you usually address that?
Yeah, so there's so much misinformation about nutrition out there because it's such a hot topic now. So I usually tell patients that until there's really good data for a diet, I'm not going to endorse it per se. However, if I think it's safe for you, like a dietitian can guide you through it. A lot of times it'll just be your own personal preference. Like we kind of, covered about the keto diet. That is one that I wouldn't consider safe per se. Also, there's no good data that it does anything for patients with pancreas issues. So I really would not go with that one. I'd probably have to put my foot down there. But if, somebody wanted to go vegan or something like that, we can definitely, go through it together and include different types of foods in the diet that'll make the whole thing complete.
Excellent. That's really helpful. Thank you. One of the other questions that we received actually is about applications, apps that you can download from various sources. I know again that we're not here to recommend any specific brand names, but are there certain apps that you have found that are useful to track fats or to techniques that you've suggested to patients to do so?
Yeah, so I usually tell people to start off with MyFitnessPal because it's very user friendly and it's pretty comprehensive. Like there's a lot of foods in there. And then I like that it can also, if you want to put an exercise or something in there, that's cool that it has that little added feature. I would like to see for future app developers out there, something that isn't focused as much on calories or something like that, because not all of our patients want to monitor that. And it would be more useful if they can just highlight a specific ingredient like fat.
That's great. That's really helpful. Thank you. One of the things actually that I'll take just a moment to mention again is that the National Pancreas Foundation website has a wealth of information on it. There's not a specific app associated with it, but I'll raise it for all of our webinar participants this evening as a place to go to, even to find actually pancreas disease support groups, which can be a very valuable resource in terms of understanding other people's individual situations and their prior experience. And so again, I'll just mention that it's a wonderful website that has a lot of useful information, and I would encourage everyone to visit it, after we're finished this evening. One of the other questions, Catherine, actually that looks like we're getting several versions of are about other symptoms related to eating. Can you talk a little bit about how you coach patients through management of bloating and how you recommend physical activity or dosing enzymes or things like that in relation to controlling that symptom?
Yeah, so I find a lot of my patients do suffer from other GI symptoms. So a lot of patients end up being diagnosed with IBS as well, kind of spurred on by the pancreatitis. So, it's important to have a doctor evaluate you for that to see if you meet criteria, because interventions for that might be a little different. So one thing that I like to recommend for people who may have issues like with constipation, for instance, or diarrhea actually, is use of some soluble fiber, not large amounts, but maybe just choosing foods that are higher in soluble fiber versus insoluble fiber. And that'll help keep them more regular. It'll help gel up some loose stools a little bit. And then it'll also, keep the constipation at bay. In terms of bloating, oh, that is such a tough one. I think that a big part of the bloat might be from the fat malabsorption. And so I really encourage people to try enzymes if that's a symptom that you're having. It may help with that. It is tough though, because I feel like everybody experiences bloat at some time, and it can be also treated if you do have IBS with something like a FODMAP diet. I would only recommend that though if you don't have a fat restriction, because once you start restricting FODMAPs and fat, it's like there's nothing left to eat. So if you're in a stable place from your pancreas perspective, but not from like bloating or something like that, then that might be an option for you.
Wonderful. Thank you so much. One of the other questions actually that it looks like we've gotten is about marijuana use in patients with chronic pancreatitis and the use of this for augmenting appetite and combating symptoms of loss of appetite, as well as for combating things like pain and nausea. As you see patients of all different ages and so forth, what is your experience with this, and what do you usually have as far as a conversation with patients about this?
Yeah, I think my philosophy with this is that if it works for you, go for it. Of course, in moderation. There actually are some guidelines out there for CBD usage for pain. I don't know how well they are, how validated they are, but a pain association did come out with these. So I'd be curious, Dr. Phillips, if you've seen that used at all.
That's a great question. And I would say, in pancreatology practices across the country, practices vary quite widely on the recommendation or inclusion of CBD and other marijuana-based products in the treatment of pain and, nutrition in pancreatic disease. Because the state practices also vary quite widely in terms of how they treat CBD and how it's controlled. That just patients' experience varies quite widely. It's something I would say that I certainly recommend talking with your individual providers about, and trying to maintain an open mind, regardless of what the response is about the substance. Essentially, for some patients, there are many anecdotes about it really doing wonderful things, and other patients don't have a very good experience. And so it's something I can't comment on specifically, but again, I would just talk with your individual provider about that. Excellent. In terms of the additional agents that you might use, Katherine, other agents to combat symptoms like bloating or decreased appetite, is there anything in particular that you like to recommend to patients as a tool?
So it's not really like going to stimulate appetite, but what I do counsel patients on is how to eat in a way that isn't going to make you overly full. So liquids are great. You can find very nutrient dense liquids, and those leave your stomach very quickly. So it doesn't feel like you've eaten a whole meal, but you can get in just as many calories.
Excellent. Back on the topic of supplementation, many patients, of course, if they have difficulty taking in food normally due to nausea or vomiting, they may not actually be able to keep down a lot of supplements. And so I wondered, how do you usually recommend to patients, in these situations to take oral supplementation? Is there a certain timing that you recommend, or, before or after other things that they're taking?
Great question. I am a big fan of liquid and chewable, vitamin mineral supplements, and taking them with food. That would probably be the biggest thing. And then the other thing with zinc supplementation, you want to make sure that you take it separately from copper supplementation, and calcium and iron. Like, there are certain things that you need to separate from each other just to make sure you absorb them better. But in terms of tolerance, I really believe strongly in chewable and liquid forms.
Excellent. Wonderful. It looks like there are a couple of questions actually about the consistency of stool in patients with various types of pancreatic disease. And so maybe I'll just take a moment and mention that stool consistency is, again, quite variable from patient to patient. And there are a lot of different things that go into stool consistency. That can include what you've just eaten, the state of your pancreas, and any other underlying digestive problems that a patient may be having that can influence the amount of water that's secreted at the same time, or other components that are coming out at the same time as stool. And so in general, the most important things are to make sure that a patient is not having diarrheal symptoms that are causing them excessive loss of fluids or excessive loss of calories. And so, as Katherine has already mentioned, the use of pancreatic enzyme supplementation is very important in terms of helping to digest food as it travels through the intestines and allow it to be taken up at the correct location. The presence of fatty stool, where a lot of fat is being lost through the stool, as I mentioned earlier, that's a medical condition that's called steatorrhea, and that is a phenomenon that is frequently described in patients with chronic pancreatitis. That is, however, not a universal phenomenon. And so it's something, again, that if you feel that you may be having that sort of symptom, something to talk to your individual provider about. All right. A question for you, Katherine. Do you ever worry about patients taking too much Creon?
Yeah, I don't worry about it, but there is an upper limit for pancreatic enzymes, and I don't know if they'll post slides or whatever, but on one of my slides, there's recommended maximums for them. I only worry about maximums in my cystic fibrosis patients who maybe need something very close to that. As far as my pancreatitis patients and surgical Whipple patients, I haven't had to worry about it, fortunately. How about you, Dr. Phillips?
It's a great question, because sometimes it can feel like you're really taking quite a lot of pills, whenever you're taking Creon with every meal. I agree, there is an upper limit of Creon. There are very few side effects of Creon. However, the single kind of most dramatic side effect of Creon is a disorder called fibrosing colonopathy, essentially where Creon, or their pancreatic enzymes, can travel very quickly through the digestive tract and land in the colon, and cause scarring of the colon if they, happen to all open at that location. Now, this is a very, very rare phenomenon, and so it's not something that I spend really much of any time worrying about. However, it has been documented, and so that's the rare consequence of potentially too much Creon. However, much more frequently, I see patients not taking enough pancreatic enzyme supplementation. And so optimization of pancreatic enzymes can be a very delicate thing that you have to work very closely actually with your dietitian and your pancreatic providers in order to make sure that you are digesting your food and nutrients adequately.
And I just saw someone comment in the chat asking what Creon is. So I just wanted to clarify that Creon is a brand name for one of the pancreatic enzyme replacement therapies. There's a ton of them out there, but Creon is probably one of the more common ones that we see used.
One of the participants actually is asking about the fiber content of diets. And so in the setting of pancreatic malignancy, some patients are advised to avoid fiber. Can you talk a little bit about how you determine the fiber content of certain foods and what might be some examples of high fiber and low fiber foods?
I'm sorry, I missed the beginning of the question.
Oh, no problem. Just that some patients are recommended actually to take a low fiber diet if they have conditions that might cause them to not tolerate fiber. Can you give some examples of high fiber and low fiber foods?
Yeah, sure. So low fiber stuff is kind of gonna, in terms of, carbohydrates, it's gonna be your, I almost want to say processed, like carbs that are refined is maybe a better word. So the white rices, white pasta, white bread, that will all have far less fiber than the whole grain or whole wheat versions of those things. And then of course, if you're having, fruits and vegetables in your diet, a lot of those contain fiber, but there are some that you can alter a little bit so that they don't have as much fiber. So anything that you take the peel off of, like a banana, it won't have as much fiber. If you're eating an apple, you can remove the skin. There are things like that that you can alter so that there isn't as much fiber in them.
Wonderful. Thank you. In terms of digesting fats and stool tests, can you review again some of the things that you were talking about with regard to the different kinds of tests to determine the amount of fat that ends up in someone's stool?
Sure. So yeah, and I saw in the chat too that someone asked a question about qualitative. So nobody likes to give a stool sample, so I'm okay with a spot sample, and our clinic will use spot because, collecting stool for 24 to 72 hours, it's a lot to ask of someone. Maybe it can be done in the hospital, but certainly at home, that's a big ask. So there's that. So you measure the amount of fat that actually is excreted in the stool. I usually tell patients that I want you to be eating a relatively high amount of fat, in the days preceding the test. If you're following a low fat diet and you get this test, your stool will not show abnormal levels of fat. So there's that. The other test is the pancreatic elastase test, which shows if your, pancreas is producing and secreting elastase, which is part of the enzyme package that it will do. And so a lot of patients regarding that ask me, can I be taking my Creon or pancreatic enzyme of any kind and still get my elastase checked? And my understanding is yes. Dr. Phillips, is that right?
Say that once more. I'm so sorry. Go ahead.
That's okay. Patients ask me if they can still get a pancreatic elastase test done if they're actively taking Creon.
Yes, absolutely.
Yeah. So that's another thing I counsel. You don't have to stop taking the Creon unless they're going to be measuring the fat.
That's correct. The amount of pancreatic enzymes that are being taken in by mouth don't affect actually the result of the pancreatic elastase test. They're different enzymes that are being measured. Excellent. One of the participants actually asks, in pancreatic disease, how often do you follow individual patients, and what kind of regimen do you usually recommend when they're having dietary difficulties?
Great question. It definitely depends on their state of nutrition. So are they malnourished? If you're malnourished and you're needing to gain weight, I might start you off seeing you once a month. or once every 2 to 3 months at most, because I want to make sure that the interventions are working and that you're gaining weight, and that we need to, we may need to adjust something in our plan. There's a lot, there's plan A, B, and C when it comes to nutrition. So I want to make sure of that. So for people who are more stable, maybe you're not malnourished and you're just, kind of navigating what foods trigger different symptoms and stuff like that, you can go a bit longer, maybe every 6 months to a year annually for people that are stable.
Excellent, excellent. One of the other participants asks us actually about kind of the trial and error of dietary strategies in pancreatic disease. And so if someone is able to tolerate a food, do you usually say that this means that it's not harming their pancreas? How do you encourage patients to think about that?
Yeah, great question. I am of the opinion that if you are tolerating it, it is okay. I will say, there's this whole anti-inflammatory, pro-inflammatory kind of thing. I don't know how well the studies are done in seeing if there's, a certain specific food that promotes the inflammation in the pancreas. I'm not aware of anything like that. Having said that, if you can incorporate more anti-inflammatory foods into your diet, that is just better for your overall health. And then as for the things that are a little bit more pro-inflammatory, just in moderation.
That's a great answer. And I would say that, I echo a lot of that. I think for many patients, they're very eager to return to a varied diet that includes a variety of elements, many of which contain, fat content or fiber content, which they sometimes can tolerate and sometimes not. And so oftentimes the best thing that we have to go by is a patient's individual symptoms when it comes to tolerance and whether or not there are any effects on their pancreas. And so I think symptoms are the most common thing that we end up using to judge that. Great.
Yes, and I also want to quickly mention someone asked about anti-inflammatory foods, what I'm talking about. And so that would be things that contain omega-3 fatty acids. Those have been found to be anti-inflammatory. So that would be things like fish, fatty fish, nuts, flaxseed, things like that. And then there's also fats that are, maybe not anti-inflammatory, but are safe, like avocado or something like that. That's a good fat choice. So then things that come from animal fats, those tend to be more pro-inflammatory. But again, including those in moderation in your diet is not going to harm you.
Excellent. Thank you so much. At this time, it looks like actually we're drawing to a close. And so I did want to just mention actually to everyone who participated this evening. First, thank you so much for attending and for all of your wonderful questions. A huge thank you to Katherine for providing all of her expertise, and to the National Pancreas Foundation for hosting this wonderful educational webinar. To all of the participants, I also just wanted to mention again, the National Pancreas Foundation has an incredible website, and I encourage you to explore it. One thing that I had forgotten to previously mention is just that there's a listing there actually of pancreas centers of excellence that have been vetted by the National Pancreas Foundation, and where many wonderful pancreatologists and additional healthcare providers like Katherine, work and strive to provide excellent care for pancreatic patients. And so I encourage you, to reach out through the National Pancreas Foundation if there is anything that that you have further questions about. For the questions that we didn't get to in the webinar, we will be happy to address those directly on an individual basis. And so I would just like to say again, thank you so much, and good night.
Thank you all.
All right. Bye.